Global Initiative for Obstructive Lung Disease. It is a scientific committee which was established in 1998, and the first report was published in 2001. And then later, the gold report is revised annually and has been used worldwide by healthcare professionals as a tool to implement effective management program based on local healthcare systems. The Gold 2022 report, which was published in 16 November 2022, it is a major revision of the Gold 2022 report. Following systematic literature searches, double-blind review by the Gold Science Committee, the Gold report has been updated to include key peer-reviewed research publication from January 2021 to July 2022. In total, 387 new references have been added to the Gold 2023 report. In the 2023 revision as follows. There is some basic changes occurred in Gold report. There is a new definition of COPD has come, new strategies for terminology and taxonomy, a new section on chronic bronchitis, additional information on screening and case finding. The ABCD assessment tool, which we used for a long time, has been revised to the ABE assessment tool, and new information on imaging and computed tomography, vaccination recommendations, and further information of therapeutic interventions, and a new definition of COPD exacerbation, and a new set of parameters to assess the exacerbation severity at the point, and issues related to the inhaled delivery, and the topic adherence of the inhaled COPD medications, a section on telerehabilitation, a section on interventional and surgical therapies for COPD, and new information on the choice of the inhaler device, and the information and figures outlining the initial pharmacological treatment and follow-up. We will discuss later in this presentation about these changes. First, background of the COPD. We all know the chronic obstructive pulmonary disease is now one of the top 3 causes of death worldwide, and 90% of its death occurs in low and middle income countries. It is an important public health challenge that is both preventable and treatable. Major cause of chronic morbidity and mortality throughout the world, and globally the COPD burden is projected to increase in coming decades because of continued exposure of COPD risk factors and aging of the population. So the new definition has come. The definition of chronic obstructive pulmonary disease is a heterogeneous lung condition characterized by chronic respiratory symptoms such as dyspnea, cough, sputum production exacerbation due to abnormalities of the airways such as bronchitis or bronchiolitis and or alveoli emphysema that causes persistent, often progressive airflow obstruction. New term, this is a heterogeneous lung condition. Why it is called heterogeneous lung condition, we will discuss later. The pathogenesis of COPD results with mnemonics, the gatomics. It involves the genetics, predisposition, environmental interactions, and occurring over the lifetime. The environmental risk factor we all know. The main risk factor is the cigarette smoking. Other environmental risk factor biomass fuel exposure, occupational exposure, and oil air pollution. Genetic factors, there is a mutations in the gene, SERPINA1 gene, which causes the hereditary deficiency of alpha-1 antitrypsin, which causes major circulating inhibitor of the serine protease. This is the trajectories of lung function, development, and aging. To realize the new term, early COPD, mild COPD, young COPD, but pre-COPD or pre-COPD, we should know this graph. Here first graph we show. আমরা এখানে যেটা দেখছি যে প্রথম যে কার্ভটা আছে সেখানে আমরা দুইটা কার্ভের একদিকে হচ্ছে FEV1টা আরেকদিকে হচ্ছে আমাদের এজ, অর্থাৎ বয়সের সাথে সাথে আমাদের FEV1টা 100% গিয়ে পৌঁছায় ইউজুয়ালি 20 ইয়ার্স এজে। এরপর ওভার দ্য এজিং প্রসেস এটা স্লাইটলি ডিক্লাইন হয়, এবং এই ডিক্লাইনটা যখন বেশি হয়ে যায় তখন সেটা COPD ডেভেলপ করতে পারে, এবং একটা দেখা যায় একটা সার্টেন এজের পরে গিয়ে আমাদের 60 ইয়ার্স বা 55 ইয়ার্সের পরে গিয়ে আমাদের COPD ডেভেলপ করছে। তো এখানে আমাদের এই গ্রাফটা বোঝার দরকার সেটা হচ্ছে যে COPD ডেভেলপ করছে আমাদের এই এজে গিয়ে, কিন্তু পেশেন্টের এই প্যাথোজেনেসিসটা শুরু হচ্ছে এইখান থেকে, অর্থাৎ এখান থেকে যে ডিক্লাইনটা হচ্ছে এই জায়গাটাকে বলা হচ্ছে আর্লি COPD। সেটা আসলে বায়োলজিক্যাল আর্লি বলা হয়, এটা আসলে আইডেন্টিফাই করা, ক্লিনিক্যালি আইডেন্টিফাই করা সহজ হয় না। আরেকটা হচ্ছে ইয়ং COPD। আমরা জানি যে COPD হচ্ছে একটা অ্যাডাল্ট এজের COPD, সাধারণত 60 পরে হয়। যদি 20 থেকে 50 ইয়ার্সের মধ্যে কারো COPD ডেভেলপ করে তাহলে সেটাকে বলতেছি আমরা ইয়ং COPD। আরেকটা কার্ভ যদি আমরা খেয়াল করি, নিচের কার্ভটা, সেই কার্ভটার মধ্যে আমরা দেখতেছি কিছু মানুষের ক্ষেত্রে তারা 100% FEV1 অ্যারাইজ করতে পারে না, কারণ হতে পারে তার লো ব্লাড ওয়েট বা চাইল্ডহুড কোনো রিপিটেড ইনফেকশন এসব কারণ। তাদের ক্ষেত্রে স্লাইড ডিক্লাইন হলেই আমরা দেখতেছি তাদের ক্ষেত্রে সিওপিডি ডেভেলপ করতে পারে। এখন যদি আমরা উপরের গ্রাফটা চিন্তা করি যে এই পজিশনে যে পেশেন্টটা আছে, এই পজিশনে তার সাইন সিমটমসগুলো থাকবে, কারণ এফিবিয়ান ডিক্লাইন হচ্ছে, কিন্তু এফিবিয়ান বাই এফবিসি রেশিওটা আমাদের লেস দেন 0.7 হয় না, এই জন্য আমি তাকে সিওপিডি বলছি না। অর্থাৎ এই যে ডিক্লাইন হচ্ছে এই অংশটাকে আমরা বলতেছি প্রি সিওপিডি পেশেন্ট, যাদের হচ্ছে আমাদের সাইন সিমটম থাকতেছে কিন্তু রেশিও অল্টার হয় না, অর্থাৎ ফিক্সড এয়ারওয়ে অবস্ট্রাকশন হয়। আরেকটা গ্রুপ যেটা আমরা দেখতেছি এই জায়গাটার মধ্যে আমরা দেখতেছি তার রেশিওটা ঠিক আছে, কিন্তু আমরা এফিবিওয়ান লেভেল যেটা সেটা দেখতেছি সে 80% এর মধ্যে আছে, অর্থাৎ এফিবিওয়ানটা অল্টার্ড আছে, অর্থাৎ প্রিজার্ভ রেশিও বাট ইম্পেয়ার্ড স্পাইরোমেট্রি। তাহলে এই জিনিসটাকে আমরা বলতেছি প্রিজম। তাহলে নেক্সট যে দুটো টপিকস আছে প্রি সিওপিডি, where the patient have the respiratory symptoms and or other detectable structural or functional abnormalities in the absence of airflow obstruction on forced spirometry. This group is important because this may develop persistent airflow obstruction COPD over time. So we can intervene this group early, then we can prevent the production of COPD. Then another term is PRISM. The preserved ratio FEV1 by FVC is greater than 0.7 after bronchodilation, but impaired spirometry FEV1 FVC is less than 80% of prevalence. And this prevalence is 7.1 to 20.3%, is particularly high in current and former smoker. And it is not always a stable phenomenon and can transmission to both normal and obstructed spirometry over time. So not all individuals with pre-COPD or PRISM will eventually develop fixed airway obstruction over time and COPD, but they should be considered patient and as such they deserve care and treatment. এবং গোল্ড এখানে বলতেছে এখানে তাদের একটা গ্যাপ রয়ে গেছে যে তাদেরকে আমরা পেশেন্ট হিসেবে কাউন্ট করব, কিন্তু তাদেরকে আমরা কি ট্রিটমেন্ট দিব সেটা হয়তো বা নেক্সট আমরা রিভিশনে আমরা পেতে পারি। Another risk factor for COPD is the asthma and airway hyperreactivity. Chronic bronchitis is a risk factor for COPD. It is common but variable condition in patients with COPD. We know the chronic cough, sputum production for at least 3 months per year for 2 consecutive years in the absence of other condition that can explain this symptom is known as the chronic bronchitis. And its prevalence is 27 to 35%. Is large observational studies in patients with COPD. So in young adults without history of asthma or normal lung function, the presence of chronic cough and sputum identified a subgroup of high risk of developing COPD independently of smoking habits. Another, in adults less than 50 years of age, chronic bronchitis without airflow limitation represents an early marker for susceptibility to the long-term COPD and all causes of mortality. So in patients with advanced emphysema, chronic bronchitis has been associated with increased hospitalization and mortality. Infection is a risk factor for COPD. Is a severe childhood infection, chronic bronchial infection, especially by Pseudomonas infection, tuberculosis, HIV. Sex is better in men than women, but later the smoking prevalence is increasing in female, so it is ratio comes to normal, equal from male and female. Low socioeconomic status is more vulnerable to develop COPD. So now the proposed taxonomy for COPD according to the risk factor for what we call it heterozygous disease. There is a COPD, genetically determined COPD, COPD-G, COPD due to the abnormal lung growth, this COPD-D, and environmental COPD has 2 parts. One is cigarette smoking, COPD-C, another is other pollution or biomass pollution, COPD-P. And COPD due to infection, we call it level it COPD-I, and COPD along with asthma, we call it COPD-A. And COPD of unknown cause, it is COPD-U. The clinical indicators for considering diagnosis, we already mentioned that there is a symptoms, we can respiratory infection and having risk factors. Then we do a spirometry, and after doing spirometry, when we get the restriction of the FEV1 or by FVC ratio is less than 0.7 after post bronchodilation, it is labeled as chronic obstructive pulmonary disease. Then to see the severity, we according to FEV1 level, we classify it into 4 classes. One is mild, when FEV1 is greater than or equal to 80%, moderate 50% to 79%, and severe 30 to 49%, and less than 30% regarded as very severe. To classify the patient into grouping for treatment management, we have to quantify the dyspnea scale of the patient. For this, we use two scale. One is MMRC scale, Modified Medical Research Council scale, and another is chronic obstructive pulmonary disease assessment tool. So, there are the changes here in the AB assessment tool. Previously, it was ABCD assessment tool. Here there is two arms. One arm is the symptoms, another arm is exacerbation. When patient's MMRC score is 0 to 1 or CAT score is less than 10, and there is there is 0 or 1 moderate exacerbation, we label it group A. And when there is a MMRC score is greater than or equal to 2 or CAT score is greater than or equal to 10 or more symptomatic patient but no less exacerbation, we regard it as group B. And another group, there is a when patient has the exacerbation, 2 or more moderate exacerbation or 1 exacerbation leading to hospitalization, irrespective of symptoms, we label it E. So there is 3 groups, A, B and E. So rule of experiment you already know for the diagnosis and the severity assessment for follow-up assessment. And there is a new term comes in screening and case finding in 2023 report that the screening permit is indicated in those with symptoms or risk factors greater than 20 packs years smoking, recurrent chest infection, early life events. The diagnostic year of COPD is relatively high. But goal tried to develop a novel approach to screening have been developed that incorporate exposure, symptoms and healthcare utilization and simple peak flow measurement. One of these has been developed for low and middle income countries, has shown discriminatory properties. So COPD case finding tools have been created based on the existing epidemiological literature, expert opinion or with multimodulary approach. And combination of questionnaires with simple physiological measurement enhance the operating characteristics and performance of this approach. So other physiological tests we are doing in COPD. One is lung volume. We know that residual volume is increased in COPD. Another is carbon monoxide diffusing capacity of lung. Previously, we mainly do this test for DPLD patient, but in COPD patient find symptoms disproportionate to the degree of airflow obstruction or low DLCO. We can do the DLCO, or before surgical lung dissection we do DLCO, and low DLCO value precludes the surgical lung revision. And smokers without airflow obstruction, the value is less than 80% predicted signal as an increased risk of developing COPD over time. So other physiological tests, oximetry and altered blood pressure analysis, exercise testing, imaging chest X and computed tomography. There is new information regarding the computed tomography in COPD patient to identify the differential diagnosis. When the patient has frequent exacerbation or excessive cough or sputum production, raising concerns of bronchiectasis. To exclude bronchiectasis, we should do a CT scan of chest. Or before doing another treatment option for COPD is a surgical lung volume reduction. So before lung volume reduction, we should do a CT scan to identify the emphysema position. And for lung cancer screening, the patient who COPD are more vulnerable to develop the lung cancer. So annual low-dose CT scan is recommended for lung cancer screening in patients with COPD due to smoking according to the recommendation for the general population. So there is 3 indications for doing CT scan in COPD patient. Another physiological test we can do when we suspect the patient alpha detection deficiency, composite score such as body index or biomarkers such as CRP or circulating eosinophil count. Goals for the treatment of stable COPD is reduce symptoms and reduce risk. And we know the bronchodilatation is the stable COPD patient is the main cornerstone of the treatment. And the combination treatment of SABA-SAMA is superior than the monotherapy. And LAVA-LAMA significantly improve the lung function, dyspnea, health status, and reduce exacerbation rates. This is evidence A. And LAMA have the greater effect on exacerbation reduction compared to the LAVA. So combination treatment with LAVA and LAMA increases the FEV1, reduce symptoms compared to the monotherapy. And combination treatment with LAVA-LAMA reduces the exacerbation compared to monotherapy. And single inhaler therapy may be more convenient and effective than the multiple inhalers. So single inhaler therapy, we should choose single inhaler therapy for 2 drugs, LAMA and LAVA. So initial pharmacological management treatment. Here group A, we previously know that there is a bronchodilator. We can use short-acting bronchodilator, we can use long-acting bronchodilator, or either LAMA or LAVA, which suits the patient. And group B, we choose LAMA and LAVA combination. and single inhaler therapy is more convenient. And group E, we already know the group E is the group of exacerbation, or more exacerbation or one major exacerbation which leads to the hospitalization. Here we use LAMA-LABA. In addition, where there is indication of using inhaled corticosteroid, we use inhaled corticosteroid. The indication of inhaled corticosteroid, it is strongly favored when the COPD having the exacerbation and blood eosinophil count is better than or equal to 300 cells per microliter, and history or concomitant asthma. And favoring on moderate exacerbation and blood eosinophil count is 100 to 300 cells per microliter, and against use when there is a history of repeated pneumonia, blood eosinophil count is less than 100, and history of microarterial infection. So these are the commonly used maintenance medications in COPD. We already mentioned the LAMA-LABA. The drugs are formulations are mentioned here. So appropriate LABA emphasized in this GOLD 2023 report. The GOLD emphasized on the appropriate inhaler device and appropriate inhaler technique. So appropriate inhaler device, we should think about the patient's belief, satisfaction, current and previous device, and preference need to be assessed and considered. A number of different device types should be minimized for each patient. Ideally, only one device should be used. And patient's cognition, dexterity and strength must be taken into account. And patient's ability to perform the correct specific inhalation maneuver for device must be assessed. How we assessed? For DPI, only if the patient can make a forceful or deep inhalation, they are suitable for DPI prescription. And metered inhaler, to later extent, soft mist inhaler require coordination between the device triggering and inhalation, and patients need to be able to perform slow and deep inspiration. Here we can use the valve holding chambers or spacer, but which patient unable to use the MDI with or without spacer or valve holding chamber, the nebulizer should be considered other factors to consider, including size and portability and cost. And smart inhaler should be useful if there are issues with adherence, persistence of inhalation technique, where dose, number and duration are mentioned over the inhaler. These are called the smart inhaler. The key points of inhalation of the drug: provide instruction and to demonstrate the proper inhalation technique. To ensure the inhaler's technique is adequate and rechecked at each visit, the patients continue to use their inhaler correctly. And inhaler technique and adherence therapy should be assessed before concluding that the current therapy is inefficient. So other treatment modality, there is an anti-inflammatory therapy in stable COPD, inhaled corticosteroid. We already mentioned the indication. Oral corticosteroid, glucocorticoid, we usually use it in exacerbation only for short duration, such as 5 days. Phosphodiesterase 4 inhibitors, antibiotics we use in exacerbation or short duration, but where there is a history of exacerbation is more, we can immunomodulate use azithromycin for a long time period of time. These are the other pharmacological treatment, and the non-pharmacological treatment, which is very important for COPD, but there is no change in 2023 report. We know the education and self-management, pulmonary rehabilitation, vaccination, nutrition, treatment of hypoxemia, and intervention, bronchoscopy and surgery. There is a new term which we previously found in 2022 report. The alternative to traditional approach is the telerehabilitation, and more relevant in the COVID-19 pandemic era, where in-person or pulmonary rehabilitation has not been feasible. And variety of telerehabilitation delivery platforms such as video conferencing, telephone only, website telephone support, mobile application with feedback, centralized hub for people to come is safe and has similar benefit to those of center-based pulmonary rehabilitation across the range of outcomes. So telerehabilitation have some lackings. The lackings of standardized of delivery platform, lack of test performed remotely allowing the accurate exercise prescription, lack of information on suitable variation in components and timing of intervention, and evidence about the duration of benefit. So in order to ensure the pulmonary rehabilitation is accessible to all, we must understand the barriers that might be unique to telerehabilitation. So vaccination for stable COPD. There is no changes of vaccination in the influenza vaccine or SARS-CoV-2 vaccine. There is a change in the CDC recommends on the pneumococcal vaccination. Previously we used pneumococcal conjugate vaccine PCV 13, and now there is a use of PCV 20 or 1 dose of 15 valent pneumococcal conjugate vaccine followed by 23 pneumococcal polysaccharide vaccines. No change in the other vaccination. There is whooping cough, Tdap vaccination to protect against the pertussis, who are not vaccinated in the adolescents, and other vaccines, zoster vaccines after 50 years COPD patient we can prescribe. There are some changes in the interventions. The overview the current proposed surgical and bronchoscopic intervention in patient with COPD. First changes are in the disorder where there is bronchitis. There is a nitrogen cryospray rheoplasty. Phase 3 trial already completed regarding this maneuver, and another exacerbation when patient comes with exacerbation, then we can do the targeted lung denervation. This is also in phase 3 trial. And other maneuver that we already know in case of bulla, giant bullectomy, large airway stenting, endobronchial valve, coil, thermal vapor ablation, lung sealants, lung volume reduction surgery, and lung transplantation are present previously. And nitrogen cryospray are the procedure where এখানে যেটা করা হচ্ছে যে নাইট্রোজেন একটা লিকুইড নাইট্রোজেনটা স্প্রে করে দেওয়া হচ্ছে এয়ারের মধ্যে, এতে করে এয়ারের যে ইপিথেলিয়ামগুলো যেগুলো ডিস্ট্রাক্টেড হয়ে গেছিলো, স্ক্যারিং হয়ে গেছিলো, ওগুলো নষ্ট হয়ে যাচ্ছে এবং পরবর্তীতে রিজেনারেট করতেছে একটা ভালো ইপিথেলিয়াম। আর একটা রিওপ্লাস্টির ক্ষেত্রে এটা বলা হচ্ছে একই কাজটা করা হচ্ছে, এখানে ইলেকট্রিক্যাল কারেন্ট ব্যবহার করা হচ্ছে, স্লো কারেন্টটা ব্যবহার করে রিওপ্লাস্টিক ওই ইপিথেলিয়ামটাকে ডিস্ট্রয় করা হচ্ছে। আর টার্গেটেড লাং ডিনার্ভেশন যেটা করা হচ্ছে, এখানে বলা হচ্ছে যে একটা ক্যাথেটার দিয়ে রেডিও ফ্রিকোয়েন্সি অ্যাবলেশন দিয়ে প্যারাসিম্পেথেটিক যে স্টিমুলেশনটা সেটাকে অফ করা হচ্ছে। এটা ট্রায়াল ফেজ 3 ট্রায়াল আছে, হয়তো সামনে আমরা এই ধরনের মডেলিটিগুলো পাবো। These are the management of COPD. We already discussed about this. First to diagnose, then initial assessment to assessment to the whole AB, then treatment, some non-pharmacological management, some pharmacological management. Then we review the patient and then adjust the pharmacotherapy or non-pharmacological therapy. These are the follow-up of the pharmacological treatment. Here we see the patient may come with us. The initial treatment is appropriate. Then patient will go for this treatment. But if there is no appropriate, but patient having the symptoms of dyspnea or patient having the history of exacerbation, we should first consider the patient inhaler technique, possible drug adherence, the treatment treatable trait, and other comorbidities. And then after correction of this, while patient having the dyspnea on LABA, we should add LABA combined. And then consider switching the inhaler device or molecules, implement to escalate the non-pharmacological treatment and investigate the other cause of dyspnea. And in case of exacerbation, the patient is on LABA, we first switch to the LABA plus LAMA, and then we try to find out the inhaled corticosteroid indication. When there is the eosinophil count is greater than 300, we add inhaled corticosteroid, and there is no, and or after inhaled corticosteroid use, when there is a patient FEVR level is less than 50% and chronic bronchitis patient, we can add roflumilast, or in case of frequently former smoker, we can add azithromycin. Some therapeutic intervention to reduce COPD mortality. বোর্ড কিছু আরসিটি চালাই দেখছে যে কোন থেরাপিউটিক মডিফিকেশনটা দিলে পেশেন্টের মর্টালিটিটা কম হয়, এবং এখানে যেটা দেখা গেছে লামা আইসিএস, সিভিয়ার পেশেন্ট যাদেরকে সিলেক্ট করা হয়েছে তাদেরকে লামা আইসিএস তিনটে দেওয়া হয়েছে, তাদের ক্ষেত্রে দেখা গেছে যে তার মর্টালিটি রেটটা কম হচ্ছে। আদার নন ফার্মাসিউটিক্যাল মেডিকেশনের মধ্যে বাকিগুলো দেখা যাচ্ছে। আরেকটা নতুন ডেফিনেশন আসছে হচ্ছে এক্সারবেশন অফ সিওপিডিতে এই গোল্ড আপডেটের মধ্যে, সেটা হচ্ছে গিয়ে exacerbation of COPD now defined an event characterized by increased dyspnea and or cough or sputum that worsen less than 14 days, which may be accompanied by tachypnea and or tachycardia, and is often associated with increased local and systemic inflammation caused by infection, pollution, or other insult to the airway. The new definition has come. There is a time limit less than 14 days, and there is a symptoms tachypnea and or tachycardia, and patient has a features of associated with increased local or systemic inflammation, mainly due to the by infection, pollution, or other insult to the airway. So classification of exacerbation of COPD. It is done after management of the COPD. When the exacerbation of COPD, when patient treated with a short-acting bronchodilator, we can call it mild exacerbation. When treated with SABA, short-acting bronchodilator, and with oral corticosteroid and plus minus antibiotics, we call it moderate exacerbation. And when patient requires hospitalization to visit the emergency room, severe exacerbation may also be associated with acute respiratory failure. Then we call it severe exacerbation. And when patient comes with exacerbation, we should look for the other comorbid condition or coexisting condition which can hamper this dyspnea, or in case this dyspnea there is pneumonia, pulmonary embolism, heart failure, pneumothorax or pleural infection or myocardial infarction. So diagnosis of assessment, gold new form is এই গোল্ড গাইডলাইনের মধ্যে এই ফর্মটা নতুন করে অ্যাড করা হয়েছে। এখানে স্টেজ 1 এ আমরা যেটা করব, কমপ্লিট এ থরো ক্লিনিক্যাল অ্যাসেসমেন্ট ফর এভিডেন্স অফ সিওপিডি অ্যান্ড পটেনশিয়াল রেসপিরেটরি অ্যান্ড নন রেসপিরেটরি কনকমিনেন্ট ডিজিজ, অলরেডি আমরা ডিসকাস করেছি। এবং তারপর অ্যাসেস করব সিমটমস, সিভিয়ারিটি অফ ডিসনিয়া ক্যান বি ডিটারমাইন্ড বাই ইউজিং দ্য ভিজুয়াল অ্যানালগ স্কেল অ্যান্ড অর ডকুমেন্টেশন অফ দি প্রেজেন্স অফ কাফ অ্যান্ড সাইন্স, tachypnea, tachycardia, sputum, volume or color, and evaluate the severity of using appropriate additional investigation such as pulse oximetry, laboratory assessment, CRP, and arterial gas, and establish the cause of the event, viral, bacterial, and environmental and other. Then treated the cause. These are the COPD and comorbidities, which are, we know that some disease coexist with the COPD, which can impact its prognosis. And these comorbidities may be present independently or sharing the same risk factors. Thus, the cardiovascular disease are more common: the heart failure, ischemic heart disease, arrhythmia, peripheral vascular disease, hypertension, lung cancer, and bronchiectasis, obstructive sleep apnea, periodontitis, dental hygiene, metabolic syndrome and diabetes, GERD, osteoporosis. Both anemia and polycythemia both can happen. Anemia occurs due to the anemia of chronic disease, to systemic inflammation, and polycythemia occurs secondary to the hypoxemia. And anxiety and depression and cognitive impairment and new term of frailty, the presence of 5 components, that is weakness, slowness, exhaustion, slow physical activity, and unintentional weight loss. Now, there is no change in the COVID-19 management of COVID-19 and COPD concomitant disease. We can treat the COPD as usual management and treat COVID-19 infection in COVID-19 guidelines, according to COVID-19 guidelines. These are the COPD follow-up checklist, and this is our World COPD Day. এবারের যে প্রতিপাদ্য ছিল যে you learn for life. Thank you audience for patience.
ধন্যবাদ শরীফ হাসানকে সুন্দর উপস্থাপনার জন্য। এখন প্রশ্ন উত্তর।